Hi, good morning. My name is Emily Zyborowicz. I am the Manager of Research and Identification at the Peterson Center on Healthcare. On behalf of the center, we'd like to thank the National Academy of Medicine for hosting this series of workshops, and all of you who are joining with us today in person and online. Also, thanks to our partners, the Bipartisan Policy Center, the Harvard School of Public Health, the Commonwealth Fund, for collaborating with us to find the most promising models of care for high-need patients. Our mission at the Peterson Center on Healthcare is just that, to identify proven solutions that improve the quality of care and lower the costs and accelerate their adoption on a national level. In the current system, those who have the greatest health needs and the fewest resources to pay for it are receiving inadequate care, and it's causing a disproportionate amount of spend in that area. Many solutions have been proposed to better serve the growing number of high-need patients. Unfortunately, many of these efforts have been sporadically coordinated. As Peter has mentioned, there's pockets of excellence throughout, but they're not talking to each other. It's not spreading. The variation that results is a variation in outcomes and costs. This variation is a cause for concern because it means that we have an underperforming healthcare system and one that is financially unsustainable. It also leads to lower quality care for people who need it most. At the same time, this variation suggests that there are pockets of excellence where better care is being delivered at a lower cost, and this is our opportunity here. As Peter mentioned, we hear statistics, 5% of Americans account for almost 50% of the health spend. So doing better in this area could really improve millions of lives and free up wasted resources. To make progress, we need to know more about these patients who have the most significant healthcare needs and the services that they utilize. We need to identify and validate the care delivery models that generate the above average health outcomes and lower than average costs. Lastly, we need to transfer this knowledge and know-how to promote the broad adoption so that the models of excellence can become community standard. A first step and one of our goals for this project and these workshops is to build consensus on what the metrics should be to measure the quality and cost outcomes of models of care targeted towards high-need patients. We intend this to be an iterative process. We hope that the discussions here today shape the analyses conducted by our colleagues here, and we look forward to having you back joining the subsequent workshops as well, and where our partners will share their findings. Thank you again for your participation, and I'll hand it off to Bill, Katherine, and Jose, who can elaborate further on their efforts in this project.
Thank you, Emily. I'm Bill Hoagland. I'm the Senior Vice President at the Bipartisan Policy Center. All cards on the table, I represent the R side of the equation, though there are days when I wonder whether the Republican Party would still accept me. But anyway, the Bipartisan Policy Center is very pleased to join the National Academy of Medicine, Harvard School of Public Health, and the Commonwealth Fund in this project. I will say, Michael, that I've been in this town a long time, and NAM to me means the National Association of Manufacturers, and so I got to get my mind around NAM being National Academy of Medicine. But you're manufacturing good health, right? I'm going to quickly turn this over to Katherine, who is the Director of Health Policy at the Bipartisan Policy Center and who is managing specifically the work we are doing with the Peterson Center on this particular project. Before I do, though, for the benefit of those who may not be familiar with the Bipartisan Policy Center, we're a relatively new organization in this town, established in 2007 by 4 former majority leaders of the United States Senate, former Senate majority leaders, Senator Bob Dole, George Mitchell, Tom Daschle, and the late Howard Baker. We are not nonpartisan. We are not the fuzzy middle. We are not no labels. We are bipartisan and working across the political spectrum to address some of those major public policy issues that confront the country. It's not easy being bipartisan in this town, I can assure you. Of course, one of those challenges has already been mentioned a number of times here this morning, is managing that 5% of the population that account for 50% of the healthcare cost, and that's the nature of this project. Now, my responsibilities at the Bipartisan Policy Center is overseeing and managing the work we do there in three broad areas of healthcare writ large, and I believe they all impact directly or indirectly patients defined here as high need. The first is prevention initiatives under the senior advisors of Dr. Bill Frist and Alice Rivlin, two old bosses of mine, and former Secretary of Agriculture Dan Glickman. We're focusing on prevention issues. There's a second area, another area that we're dealing with is on health technology and innovation areas. Right now, we will have a report coming out later this month on advancing medical innovation, focusing specifically on the FDA and the Cures Act that Congress will be considered later this week, or at least the House will. And finally, then Katherine's area, the broad area of health policy, with a particular focus on the payment and delivery system, long-term services and support, and insurance coverage. Here we have, and you'll see the difficulty of bipartisanship, we have senior advisors being Senator Tom Daschle and Bill Frist, Secretary Tommy Thompson, Alice Rivlin, and recently joining the insurance coverage team, Newt Gingrich. So wide spectrum here, but can you find policy consensus? To me, that's the only way to move policy forward in this country is in the consensus area. One last project I should mention, recently launched, focuses on housing and aging, led by two former HUD secretaries, Cisneros and Martinez, and former Representatives Vin Weber and Allison Schwartz. I mention this other work at BPC because in the end, I believe, and I think we believe, and I think probably this audience would agree, that patients referred to as high need require a range of medical, behavioral, social, long-term support services, all which need to be coordinated. And hopefully the work we are doing beyond just the Peterson project can help inform our thinking and recommendations in the work that Katherine will now outline specifically for you on this project. Thank you.
Thank you, Bill, and thank you for including me today. Thank you to the Peterson Center, and looking forward to working with both Harvard and IOM on this project. As Bill mentioned, we have 3 health projects at BPC, and when asked to lay out my scope, I think it's easiest to say that I have all the high-risk, low-reward issues at BPC. So what is BPC's role in this project? What we are doing right now is drawing from existing literature, and we'll be partnering with Harvard and IOM as they work to identify care models and to identify target populations. Once that work has been done, BPC will be looking at policy recommendations to ensure that these coverage models are aligned with reimbursement models to permit scaling. Specifically, we'll be looking at the Medicare and Medicaid programs as well as other social programs and see where we can find alignment to allow scaling of these models. Those of you who know Bill Hoagland know that there will be a component to determine the budgetary impact of our policy recommendations. We'll be looking at the Medicare and Medicaid scoring on this. The next component of once we have our policy recommendations, we will filter those both politically and again through the budget process. So that is one step that we often take. You know, we find recommendations that make good policy, but they may not work on the Hill or within the administration. So we work with stakeholders to make sure that what we put out there is politically viable and has some chance of moving forward in the short term or even over the long term. And lastly, we make policy recommendations in a sufficient level of detail to both permit the scoring, but also to allow policymakers, Hill staffers, agency officials, to draft legislation or to write regulations based on that level of work. So in terms of where we are right now, we are currently drawing from the literature that is out there, and we have begun outreach to stakeholders. Those stakeholders include health plans, healthcare providers, states, businesses, and consumer representatives. We're building on our recent work on transitioning to organized systems of care, focusing on integration of Medicare and Medicaid services, looking very closely at the existing duals demonstrations and what lessons can be learned to date. We are developing a preliminary list of policy options to address barriers to integration. And when we think about this, so traditionally, being a former Hill staffer, I look at the existing Medicare and Medicaid programs and think, okay, what can we do to change these two programs to make them work better together? And we are certainly doing that, and we'll be making incremental changes, recommendations for incremental changes. But we're also sort of turning this issue on its head and thinking, if we built something from the bottom up, what would it need to include? Who would be eligible? What benefits? How do we capture the existing dollars in the system so as not to create some sort of new entitlement program? So I would welcome those of you who have, all of you who have expertise in this area, please contact us. I know we will be reaching out to some of you and already have reached out to some of you. But to help us think about both of those aspects of care, both the incremental changes that can be made, but also if we were going to start from the bottom up and create a new program that allowed full integration of acute and long-term services and supports, what would need to be in there? How much flexibility would states and the federal government need to have? And what type of protections would need to be there, both physical protections and beneficiary protections? And finally, Acumen will be working with us to score these models. So with that, I'll turn it over to Jose.
Hi, everybody. My name is Jose Figueroa. I'd written what I wanted to say, but I guess Peter actually went through my entire bit. And so, you know, when I was a kid, my mom used to always tell me to write everything you were going to say because I had very disorganized thinking. So it'd take me forever to ask a question. So what she didn't say is, if somebody else already mentioned everything, then what should I do in that instance? But the recurrent thing that you'll hear is that high cost, high need patients are a very, very heterogeneous group. As Peter was mentioning, they tend to be disabled, they're frail, they have multiple chronic conditions, they have the behavioral health and substance abuse issues, they tend to be more often than not socioeconomically disadvantaged and ethnically diverse as a population. And so the work that we are trying to do at the Harvard School of Public Health, and thank you for choosing us as a partner, is to sort of try to provide an analytical framework that allows us to sort of define, go from a heterogeneous population to a much more homogeneous subgroups, both clinically and socially meaningful segments. So with our work, you know, things that we're going to try to understand is what are the specific characteristics associated with high cost, high need patients within these segments. How do utilization patterns differ between these segments and within the segments? And then importantly, what proportion of the spending and utilization could have been prevented among the segments? Prior work from our group suggests that about 40% of ED and inpatient cost of high-cost patients, the top 10%, could have been prevented as compared to about 15% of the non-high-cost patients. So there's obviously a huge gap. There's something happening with the high-cost, high-need, and as you'll probably hear throughout the day, some of the reasons why that may be the case. And at the end, we are hoping that our work allows us to identify characteristics of providers and health systems, whether it be ACOs, medical care home models, that are most effective for caring for these patients. To give you an update where we're at, we have been spending, with the help of the Commonwealth, the past 9 months working with the Medicare population. We've also spent about 6 months looking at a subset of commercial patients. And then finally, with the help of the Peterson, we are just initiating our analysis on the duals. We just obtained a big data set about two weeks ago, so we're very fresh on it. It'll take us some time, and we look very much forward to presenting this body of work at the next meeting.